welcome to today's session on cholesterol management for non-clinicians. So I am the presenter today on my own, actually. My name's Sarah Partridge. I am a clinical pharmacist by background, and I also work for the Training Hub as a pharmacist associate. My other job is, as a lot of you know, I work for Nottinghamshire GP Alliance, where I provide sometimes support to our personalised care roles. And that's given me an appreciation that actually we need to be giving a bit more awareness and information to those roles so they can support the bigger picture. So this session was designed in a whole series where we're looking at cholesterol management and kind of trying to provide support for all the roles that could be involved. So just a quick disclaimer, this training is for educational purposes only, and we do get it checked. So this has been checked by a care coordinator and a GP, but it does not replace any policies, guidelines, or professional judgments. So housekeeping using Teams, I think you are all going to be familiar with Teams. So hopefully you all know where the chat function is. I'd also point and highlight the react symbols at the top because hopefully we might use that because there is a little quiz at the end. So I quite like to use that. But yeah, if you have any questions, please do ask. And we're going to go to a bit of interactivity now. So how many UK adults have a raised cholesterol? So feel free to unmute or put in the chat. So I'm thinking percentages. So is it 10%, 100%? So what do you think is the percentage of UK adults that have raised cholesterol? So I'll just give you a moment to put that in the chat. If anyone wants to unmute, feel free to do so. But you may be all on practice computers and not 30%. Thanks, Lisa. Natal, hopefully I pronounced your name right, has gone up 40%. Any more advances? These are all really good guesses. Oh, Josh has gone for 20%, Holly 35%, Marissa 80%. Any other answers before I give it away? These are all really good. So I'll just let Danny write in and then I will tell the answer, 35. So you're getting around there. So Heart UK, which is the cholesterol charity, says almost half. So Natal was closest, so brownie point to you. But yes, that's saying that there's a lot of people out there with raised cholesterol. And I suppose it's thinking about why does that matter? Because we can't see it. So this presentation hopefully will give you the background to why this matters. So the overall aim of this session is to give staff the kind of background to why we are looking at optimizing lipids or reducing cholesterol within primary care, as the 10-year plan is now shifting to a focus on prevention of ill health rather than just treating it. But the actual learning outcomes are listed on this slide that I'll let you read yourselves. I would love to say I came up with them myself, but actually a couple of years ago, a UCL partners came up with a framework of how the team should work together to look at cholesterol management. And these learning outcomes have come from them. You will be getting the slides. So any links, if you want to look at anything afterwards, then you can do so. So this session is about giving you that awareness, giving you that knowledge, but also giving you the information that you can take away to share with patients or run searches or things like that. So it's kind of an awareness and knowledge sharing session. And based on that we've got a really good team here as well. So if you have any cholesterol related resources or ways that you do things, please do feel free to share with your peers and colleagues in the chat. So when I first proposed this training to the non-clinical team at the Training Hub, I did get challenged, as in, why do they need this as they're not involved? But this is definitely not true. I know for a fact that the wider workforce can and are already involved in supporting cholesterol management. And this could be through education, could be through supporting self-management and behavior change, or this could be done then on a one-to-one basis or via targeted community events and hubs. You may also be involved in addressing patients' wider concerns because actually you're involved in personalised care potentially. And so the patient may be asking you questions because you've built that trust and rapport. Or it could be that you're involved in signposting to relevant clinical staff or services where necessary. So there are lots of ways individuals can be involved. And I've probably not touched on everything. So there's probably lots of other ways that you can be involved in supporting patients with cholesterol management. So as the video covered, cholesterol is a fatty substance, which is essential, but we often have too much. And you've got the bad cholesterol, the LDL, which Ali, who's one of my colleagues, always calls lousy cholesterol. That's her way of remembering it. And the HDL is good cholesterol. Now, I've spoken to a lot of clinicians and people about how the best way to explain like cholesterol and the formation of the fatty deposits that leads to the heart attack and strokes. And the best way I've come across is describing it as a kind of pothole. I don't know, has anyone put your thumbs up if you've ever heard of it like this? So thinking of your blood vessels like a smooth road that your blood travels along, carrying the oxygens and nutrients around your body. And over time, small cracks form in your blood vessels, and things like high blood pressure, smoking, or high sugar levels can like damage that lining in the blood vessels, and like small cracks appear like on a road surface. And then when those cracks appear, cholesterol in your blood can start, because it's quite a sticky substance, and it kind of sticks there like the dirt and debris getting into the cracks on the roads. So to start with, it will only be like a small, thin layer in that little like pothole cracks. And then it gradually builds up. So more and more cholesterol and other materials build up, forming a lump or bump. So like the pothole getting bigger. And then the road gets narrower, and like the traffic or the blood in this case can't flow as easily. And also, like potholes, they can suddenly cause a blockage because there is that lump bursts or breaks open. The body then tries to patch it up by forming a clot, but then that clot can suddenly block that flow of blood. So that's like kind of a pothole caving in and closing the road. So sometimes describing it like this can help the patient understand, because it's quite hard. You're trying to explain a kind of concept that the patient can't see the cholesterol in their blood vessels. So it's trying to come up with a way of explaining it to the patient. So hopefully maybe that pothole description might help you in practice if you're ever asked to describe it. And then, as the video explained, it's important that we find and help people with high cholesterol, because it can lead to heart attacks, strokes, angina. It's often has no symptoms, so we need to find out it's detected by a blood test or the finger prick test. And there are a lot of causes, as the video touched upon. Some we can do stuff about, some we can't, and it's about how we explain that. So linked in with this is the concept of cardiovascular risk and Q risks linked to that. And cardiovascular risk is the chance of having a heart attack or stroke in the future. And it's calculating people who haven't had a heart attack and stroke but may be at risk. And high cholesterol is a risk factor for this cardiovascular risk. So because, as we said, it forms fatty deposits, and those forms plaques that then can cause clots and that stop that flow of blood. And if you're talking to patients, it might be you need to sometimes patients might speak to clinicians who will perhaps not have explained it. They might have used jargon and things like that, or it might be that when they had a consultation that the clinician went through so many things because that actually the patient didn't quite hear everything. And sometimes you need to go through things more than once, or the patient might need signposting to some of the resources and materials. So this is an example of how do we explain cardiovascular risk to patients? How do we avoid the jargon associated with it? And this probably isn't perfect. You guys might be able to come up with much better examples, but it's about explaining about how likely you are to have a heart attack or stroke in the next few years, or a way of looking how healthy your heart is and what might affect them, and then thinking about kind of risk factors. And it's about explaining to the patient some of the things we can't change, like age or family history, and other things we can do things about. So it's like working with them and trying to think of the language that you're using, but you will be really good at that, I presume. A term often bandied around is QRIS3. Has anyone come across this tool, this online tool? You can put your thumbs up on the React if you have, or put yes in the chat. So I'm just kind of letting you aware there is an online calculator. It is not available on System 1. They still use the old QRIS2 tool, which is missing some of the information. But this is a tool or website that calculates a person's risk of developing a heart attack or stroke over the next 2 years. This does assume that they do not have cardiovascular disease and are not on statins already. But the reason why this is important is because if an individual gets a score of over 10% using this QRIS3 tool, then they should be offered a statin or other cholesterol lowering treatment. So this is why this tool is important. It estimates the likelihood of someone having a heart attack or stroke over a 10-year period. And one of the things today you might want to go away is like have a look at this tool and just see what it looks like in case anyone asked you to calculate some QRIS3s. But it's quite a good website because actually if you put all the information in and you get a score, it will also tell you their risk compared to a normal individual. So it could be that a 52-year-old actually has a heart age of a 66-year-old. So it's quite interesting in that respect. This is for information, a British specific tool. There are other tools used in Europe and things like that. But they gathered the evidence, and it's even specific down to postcodes. And interestingly, if you put in Nottingham City, like city centre, their Q risk, I did it for a patient who was pretty much healthy in all other respects, and their Q risk 3 was about 2 to 3% higher because they lived in Nottingham City compared to if I put a Rushcliffe address in, which was quite interesting, which is not well, unless they decide to move, is potentially a non-modifiable risk factor. But it was, so yeah, that's the Q risk 2. So next, we're going to move on to lipid optimization and think about blood tests and statins. So as the video touched upon, in a healthy individual, if a patient has a lipid test, it will be looking for total cholesterol, LDL, so the lousy, lazy cholesterol, the good cholesterol, and the non good cholesterol, and the triglycerides. So you'll get a lipid profile. And there are different targets, but those are generally the ones there. There is a link down there if you want any more information on there. If a patient is on treatment, they will have different targets as well. So once they've been put on treatment, the targets will then change. But this is for a general standard person. If they ask you, what are normal lipid bloods? And the reason why we check on lipids is because you can't see if a patient has high cholesterol. So we use it to monitor risk. We use it to calculate the Q risk, so their chances of having a heart attack and stroke over the next 10 years. We use it to guide treatment decisions, and we use it to monitor response to treatments. it is normally pretty obvious from a blood test if someone is taking their cholesterol treatment or not, because suddenly their cholesterol will go up quite considerably. Cholesterol treatment generally lowers cholesterol by about 40%. It depends on the treatments used, but that is a really good result for a medicine. They don't normally work quite as well as that. So it's got really good outcomes, but it also makes it obvious if someone's not taking it. So I've done a lot of talking there. And so this is back to you. So what non-medication options do patients that you might come across have to lower their cholesterol levels? And there were some hints, I think, in what's been said and in the video. Brilliant. Some people really quick off the mark. That's really good to see. So we've got exercise, yeah. Although realistically, when they said 5 times a day, I'm not sure that's always possible in all our patients. Change in diet, healthy diet, brilliant. Anything else? Stop smoking, because yeah, actually that will stop this. If you stop smoking, then that cholesterol becomes less sticky. Reduce alcohol, and alcohol has a really big effect on triglycerides, I find, in practice. So because there can be kind of causes of high cholesterol that need investigated by a clinician. That can include excess alcohol, thyroid function and things like that. Stop a sedentary lifestyle, brilliant. Just though, to challenge you there, Tolu, would a patient know what a sedentary lifestyle is? No McDonald's, no Big Macs. Everything in moderation, would you say, Josh? So some really good examples there. Are we missing anything? So we've covered diet, exercise, smoking, McDonald's. I think that generally is kind of everything. Let's just check my so the answers I have on my sheet is stopping smoking, health eating, reaching, maintaining a healthy weight, increasing exercise, reducing alcohol, and then this is about the person making their change. Now, I know a number of you are health and wellbeing coaches, and you are experts and better than me at motivating change. So it might be, if you've got a health and wellbeing coach as part of your team, what quick questions can they train you in using when you're supporting your patients? Or there is making every contact count training as well that might be really useful if you've not done it already. Thanks, Tolu. That's a better answer there for patients. And I suppose my takeaways for this is we've all got that opportunity to make every contact count. Are we aware of all the local services available to support the lifestyle changes? You are not expected to be able to cause all these changes, and sometimes it's about that cycle of change, so planting that seed. And if enough people do it at enough points, it might be the motivation that patient needs. So are you aware of all the services or support within your area that can help support these lifestyle changes? Some people, for example, might have access to a dietitian and some areas might not. So it's very important that you know what's going on in the area. And are you really good at using motivational interviewing techniques to support behaviour change? So is that an area? Some of you will be really good at it, whereas other of you that could be an area of development. So option one is lifestyle changes and diet changes. And particularly those with a Q risk, so less than 10%, we want to be working on this, because actually if we can make interventions earlier, then we can potentially impact a lot further along. So it's thinking about prevention. If someone has got a Q risk of greater than 10%, or they've had a heart attack or stroke, or potentially they're diabetic, they've got renal impairment, or they've got HIV, then we may be offering them a statin, and that's to prevent heart attacks or strokes, or further heart attacks or strokes if you've had one. And statins work by blocking an enzyme called HMG-CoA, which is part of the pathway of cholesterol being produced in the liver. It also increases the absorption of cholesterol into the blood cells. So some is taken from the blood into the liver. So in other words, it reduces that cholesterol that's flowing around the body, reduces the chances of those plaques occurring. So the one that you will see, which is used for primary prevention, is atorvastatin 20 milligrams daily. There are other ones out there, rosuvastatin, simvastatin, pravastatin, but the ones you'll generally see in primary prevention, so that's if you've got a healthy individual that hasn't had a heart attack or stroke, generally the 20 milligrams, or secondary prevention where they have had a heart attack or stroke, you'll see at the higher doses of 80 milligrams. They're generally really well tolerated, and the most of the side effects that patients experience is mild. The one that you'll hear patients kind of complaining about potentially, or might provide a barrier to them taking it, is muscle pain. But actually, they've done studies out there where they've given patients placebo tablets, so like Smarties that look like the statin, and they've given patient a statin. And they found that the incidence of a patient getting muscle pain is very, very similar. So actually, the patients getting muscle pain due to the statin is very, very rare. But so sometimes it's about reassuring the patient. It's also a bit about managing expectations, because if a patient's been told that their cholesterol is high, the chances are they will suddenly start increasing their exercise and moving more. And actually, if they're kind of back doing this after a period of being sedentary, they are more likely to get muscle pains and aches and things like that. The muscle pains caused by statins are normally in the big muscles on both sides of the body. So it's about kind of working with the patient, saying, is there persistent muscle pain in both sides of the body? Okay, we need to look into that. Is there some muscle pain because you've been doing lots of gardening and it's getting better? Probably unlikely to be caused by the statin. So the important thing to know about statins is it does require I'm just going to mute, or if they've done it already. They're monitored. We need blood tests before they start it. So normally we get liver, and we get cholesterol levels, and then we also check it at 3 and 12 months. So that's the statin. Patients are often it's a lot of information in a consultation, and we need to make shared decisions with patients to make sure that they understand the benefits of being on it, and they also understand the risks of being on treatment, including lifestyle changes as well. So I don't know if anyone's come across these decision aids. So there is a really good, nice decision aid. Again, you'll get the links to it, and it explains what the benefits of being on it, what the risks are, and what the possible side effects are. And so sometimes actually for a patient, I might give them this decision aid. Depends on the literacy and the understanding of the patient. So do bear that in mind. And then the patient will go and think about it, and then I will follow it up later. So it could be that if you're involved in care anywhere, it could be about supplying them with the decision aid so that they are aware of kind of the risks and benefits. The other really good website I quite like is gpevidence.org, which if anyone ever wants to find out about trials and the risks and benefits of treatment is a really good kind of starting place. It was created by Dr. Julian Treadwell because they found that people in healthcare generally overestimate the benefits and underestimate the risks. But the reason I like that as in practice is it shows me the smiley faces. So what happens if you don't have any treatment and what happens if you do have treatment. So that's gpevidence.org. So that's just a bit of an awareness for you about what tools and resources are out there and what shared decision aids there are. So if a patient, say, wanted more information, say they'd been offered a statin in the consultation with one of your team members, and they said, oh, we'd like more information. It could be that you give them the nice shared decision aid and then book them in with your colleague at a later date. So then you're kind of using the multidisciplinary team. So statins are not the be all and end all. It used to be that way, but a lot more treatments have been added to our repertoire. So it is generally now, cholesterol management is in a lot of QOF targets. So, and it used to be that you could just put statin declined and that would be a read code enough. So if you're involved in coding at all, you cannot get away with statin declined anymore as the code that will bring that patient off the QOF. It will actually have to be lipid management, lipid optimization declined, or the code around there. So that's a bit of a kind of useful tip there. So if a statin is declined or not tolerated or not suitable or not meeting the targets, depending what they're treating, then alternatives will be offered by clinicians. And these include ezetimibe, which kind of reduces the cholesterol absorption in the gut. So reducing then the cholesterol that's in the bloodstream. And quite often it works best in combination with the statin, but it can be used on its own. We also have in our armory bempedoic acid, which reduces cholesterol production in the liver, but further up the pathway than statins. Quite often we don't use it if a patient is on a statin, but it can be used. We just need to be careful because it can be linked with muscle pain as well. So there might be an increased chance of having muscle pain if someone is on a statin and bempedoic acid. We also need to potentially be careful if patients have gout, if they're on that medication. Another one which we're commonly more using because it gives you a really good reduction in LDL cholesterol is inclisiran. This kind of is involved in the expression of proteins on the cells, which increases the absorption of cholesterol into the cells and has been associated with lowering levels of about 50%, and involves the patient being given injections every 3 to 6 months. So really convenient. If you're thinking from a patient perspective, then actually coming for an injection every 3 months sounds ideal to me. The main limit with this treatment is, whilst it's been proven to lower levels of LDL, we haven't, because it's quite a new drug, we haven't got any outcome data of whether this actually reduces heart attacks and strokes. But the general consensus amongst clinicians that are working lipid areas is that it will be there when the trials come out. And then finally, a hospital-only medicine is this PCSK9 inhibitors, which are really good. They're even better than the inclisiran at lowering cholesterol levels. But these biologics are administered every 2 weeks or so. So that's quite a lot for patients to be going into hospital regularly, that often. But we do use them in patients who are really high risk, particularly at those who have genetically really high cholesterol levels. There are other options as well, such as fibrates and bile acid binders, but we don't see them that often in primary care. The ones that you'll see increasingly are statins, ezetimibe, and inclisiran. And as we say, it's a tool in our armory, and it should be used in conjunction with lifestyle changes. And then finally, I kind of wanted to touch upon red flags. So as non-clinicians, you're not expected to diagnose or make clinical decisions. However, I know when you're speaking to patients, they throw anything at you. So it's important that you're aware of warning signs that may require urgent attention. And if in doubt, always err on the side of caution. It's much safer to raise a concern that turns out fine than to miss anything that's serious. So signs that I just wanted to kind of highlight to look out for include sudden chest pain, pressure, tightness or discomfort, particularly if it's spreading to the arm, neck, jaw or back, because actually this could be a heart attack, because it could be that we're dealing with patients that are at high risk of heart attack and stroke. Also, if someone looks pale, clammy, or they say they feel faint or unwell really suddenly, then that could be serious. It could be a sign of a heart problem, or it could be a sign of drop in blood pressure that it could increase their risk of falls. Hopefully you're all familiar with FAST, which is the signs of a stroke. So that's the face is one side drooping, arms, can they lift both arms? I don't know why I've got to do this as well. Speech, is it slurred or strange? And the T is time, act fast, call 999. And it's important to say that even if symptoms come and go, it still needs urgent attention, because it could be a sign of a mini stroke, which then still needs investigating before they have a big stroke. If someone is struggling to breathe, speaking short sentences, or looks distressed, again, highlight that to someone. Swelling, particularly in one leg, because it could be a sign of a blood clot, or swelling in the face or throat, because that could be a serious allergic reaction. And then other things that you might need to escalate or involve clinics. It could be that a patient says to you, actually, I don't take that prescribed medicine. And it might be because you've got that trust with them that you can explore the reasons why they've chosen to not take it. Sometimes it's about side effects, or sometimes about misunderstanding or fear. It could be things like cost as well, because if they're not elderly, then they might be paying a prescription charge and things like that. So there could be a number of reasons. So it's about exploring that. And if that happens, then record their concerns and then escalate to a clinician so that they can follow up. Or again, if you come across a patient that says, actually, I'm not taking those medicines, I'm sure you all would, but yeah, documenting that down and escalating to a clinician to follow up. Some of you may also be involved in finding patients, because you might be putting on cardiovascular hubs or events, and you might want to locate which patients would benefit most. So we are all finite resources, and actually we may need to target who we're going to offer interventions to. These are a couple of tools that exist, and again, the links will get sent to you, but there's the Manchester Search and Risk Stratification tool, which proactively identifies and categorizes patients. It will come with the caveat that it was designed for Manchester, so it's probably worth just double checking, but I've had a look and it should be totally adaptable for our patients in Nottinghamshire. The other tool that's quite good, and it might be that you want to go away and find out what your local population is like, but is the CVD Prevent, and it lists how you're kind of doing, and it could be in different practices that you're working in. One could be doing really well and one could be doing really not so well, and it's like, what's that one doing which that one isn't doing? And it might be part of your role to just like highlight that. Brilliant. Hopefully been a bit of a whistle-stop tour of a bit of background to cholesterol and heart risk and things like that. But just to check you're listening, I've got a bit of a quiz. So hopefully you can all use the react buttons at the top. So if you think it's true, do a thumbs up. And if you think it's false, do the shocked face. Josh, have you got a question?
No, just
checking it works.
Yeah.
Brilliant. Well, I'm glad you're checking that. So the first question is, raised cholesterol can increase a person's risk of heart attack or stroke. Brilliant. Yeah. So that's the whole purpose of this, is just making sure that we're aware. Jason, or is that just you putting your hands up? We will have time for questions at the end. So
yeah, I was just reacting. Thank you.
So the next question is, cardiovascular risk is determined only by cholesterol levels. You're all too good at this. So yes, there's lots of factors where you live, if you've got diabetes, if you're on antipsychotics, if you're taking steroids. So loads and loads of risk factors that get your weight, your blood pressure, your variability of blood pressure. So yeah, cholesterol is only a small part of it, and there are lots of other risk factors behind it. Next question. The Q-risk tool estimates a person's chance of developing cardiovascular disease over the next 5 years. So the answer is 10. I haven't managed to catch you all out. No. Okay. Annual lipid blood tests are only needed if a patient develops symptoms. True or false? No, I can't see. I made these questions too easy. So yeah, we generally will use it to kind of, this is quite interesting. Most practices, I believe, offer annual blood tests. And I think that's really important because it's that opportunity to have that conversation about lifestyle, about checking they're taking their cholesterol medicines, and generally looking a bit more holistic at reducing cardiovascular risk. However, there are some practices that don't offer it yearly. So, for example, my aunt who lives with us, her next statin blood test is due at 5 years, which is really interesting because the evidence for taking a statin to reduce cholesterol levels is variable, but over 50% of patients are thought to have not be taking their cholesterol tablet at 1 year. So it's quite an interesting how different people. So it could be that their lipid test is done as part of their long-term condition review. We should package it up into one if the patient has more than one condition, to make it about looking after the patient. So next question. So statins are used to lower cholesterol and reduce the patient's cardiovascular risk. So true, brilliant. And finally, you're all going to get this right. Red flags such as chest pain, sudden shortness of breath, or extremely high cholesterol results should be escalated. Yes. So that was me just saying you are listening to what's been going on. So this is just kind of trying to wrap everything up. So this is just about increasing awareness, giving you resources should you be involved. So I was just having a think about what you could do to support finding patients who have high cholesterol and things. It could be that you might be involved in flagging patients who are suitable for review. It could be you're involved in supporting signposting and monitoring. If you're speaking to patients, it's important to know when to escalate. And then about just asking you, who else could be involved in like management of these patients? If you're thinking about lipid optimization and the cholesterol management is about involving the whole team. This is why it's really important that I thought I'd run this session for you today. So it's about involving the nurses, the pharmacists, the GPs, and everyone, because actually we can make the difference there. Want to find out more So link back to the learning outcomes, I have linked to resources. So if you want to go away, find out more, or if you want to have a look at the resources, like what can you send to patients if you're having, because it could be you signpost patients to appropriate resources. So it's having those and being aware of what ones to use to take that away. And then finally, just my summary is cholesterol management is an important area and helping patients live longer and healthier. We can play, all the team can play a role in identifying, supporting and signposting patients. And I suppose it's getting you started to think, what changes are you going to make practice following this session? There is a competence framework. If anyone's doing a bit of work in this area, there is a lipid management competence framework, and that does list health and wellbeing coaches, social prescribers. It's got each individual's role competence framework. So if you want to have a little look at that, and you might want to baseline where you are and what further training or support you need to do that. So it might support your development in this area. And